This is the Safere Diawara, the Ryan White. This is the Clinical Quality Management Coordinator. Ryan White. This is the Clinical Quality Management Coordinator. Ryan White. Quality of care and welcome to Ryan White. Quality. This is the Clinical Quality Ryan White Management Summit. This is the Safere. This is our third virtual Quality Management Summit, and I hope you will not experience many challenges due to the internet or other related issues. So developing and implementing quality management program are critical for all our organizations, regardless of the size, to ensure that our services and internal processes meet the highest standards by developing and executing a quality policy, as well as implementing quality assurance and quality improvement. The COVID-19 outbreak has been very challenging for us. Quality assurance and quality improvement have been affected in some places. However, we have worked very hard to maintain quality while virtually providing services to a large community. This Quality Management Summit brings together all top quality champions across the state, including all our Ryan White Part A, B, C, D, and F, and also our consumer community, to share best practices on how to survive the pandemic and what were the main action taken to drive the best values that resulted in a higher level of quality of care and services. During the 2 days of summit, we'll have handy interactions between Ryan White providers and the community partners we serve. In addition, we will share knowledge, best practices, and update ourselves with 8 plenary sessions and 8 breakout sessions. 17 outstanding presenters will share with you how to incorporate the latest best quality practices and tool into your daily routine. We will discuss exciting topic and give you many opportunities to ask questions and interact with each other through live moderated question and answer session, and also the integrated question and answer chat tool. There have been great achievement by our quality management program since the last Quality Management Summit. We have timely developed and submit to HRSA our Grand Year 2022 statewide quality management plan, along with other program term report required document. All subrecipients have timely submitted their 2022 quality management plan to VDH. Our initiated Rapid Start project has grown from 5 to 16, and we are getting ready to expand it to all our Ryan White funded sites beginning April 1, 2023. Virginia was contacted by the National Association of County and City Health Officials, called NACHO, on behalf of HRSA to participate to Ryan White Rapid Start jurisdictional playbook development project. And the related interview was completed in May 2022. The playbook will guide health department and other jurisdictions in rapid start policies and procedures. VCAC, the Virginia Consumer Advisory Committee, keeps leading the statewide quarterly peer-led psychosocial education sessions, and as well as the regional VCAC is listening session. VDH, in collaboration with the Quality Management Advisory Committee, QMAC, and the VCAC, led 4 great presentations and 1 poster presentation at the HRSA National Ryan White Conference on HIV and treatment. The presentation included one at the business meeting and the Division of State HIV Aid Program, and how Virginia conduct remote subrecipient site visits. VECEC presented also on using some innovation in quality management practice transformation to reduce isolation and stigma among people living with HIV during COVID-19. Presented on the Rapid Start Collaborative Initiative, and also during the Community Engagement 301 Institute, Virginia presented the great work of Virginia Quality Management Team in developing, engaging, and supporting the VECEC. And the VCU presented the poster on quality management through a collaborative learning process, Virginia Cross-Part Collaborative Performance Measures. Related to our quality management project, thank you for your patience through this year quality improvement project implementation process. Unfortunately, we have been unable to obtain the necessary data needed for the grant year 22 quality improvement project, viral load suppression for existing Ryan White clients who are not viral load suppressed, and those newly diagnosed. And that was due to the staffing vacancies and the ongoing delay of data. And the VDH quality management team has decided to temporarily halt on the project. And further information was provided on the quality improvement project that allows subrecipients to use internal data for the quality improvement process for the rest of the grant year. Please let me recognize the people who made this conference happen. Big thanks to the Quality Management Advisory Committee, the VECEC, the Consumer Advisory Committee, including all Ryan White Part A, B, C, D, and F partners. Thanks to the honors members of the Quality Management Summit Planning Group. Special thanks to the co-organizer, the VCU Ed Education Center, and also its contractor, Cvent. My last word of appreciation go to the Virginia Department of Health, the Division of Disease Prevention, and HIV Care Services leadership for their consistent support to the Virginia Quality Management Program, including this Quality Management Summit. I thank you all for your participation and hope you will be able to gain knowledge and from our keynote speakers. Thank you all and have fun. Safere.
Good morning, everyone. I'm Dwight Rackley, Director of HIV Education at the VCU HIV Education Program and Regional Coordinator for the Mid-Atlantic AIDS Education Training Center and the Virginia HIV AIDS Resource and Consultation Center. On behalf of the Virginia Department of Health and VCU, I am pleased to welcome you all to our annual Quality Management Summit. Some of you may have attended our other virtual quality management summits over the past 2 years and our in-person summits before the pandemic. If so, welcome back, and a big warm welcome to all of our new attendees. This virtual quality management summit is designed to provide all of our attendees the opportunity to learn new skills, quality management knowledge, and be able to network with fellow colleagues from across the state. But before I get started, I would like to express my sincere appreciation to everyone who worked so hard and helped make this virtual event come together again to become another great success. Thank you so much to our VCU team and our partners with Cvent and the Virginia Department of Health. This year's Quality Management Summit's theme is Forward Together, New Frontiers in HIV Quality Care. We've all had to learn to be resilient and flexible over the past 2 years due to the pandemic. We've all learned how to adapt to working remotely, having virtual meetings, and possibly working during staffing shortages. And remember, our clients have had to learn how to adapt as well. In the end, we've all had to do what was best for our clients. We've all had to pull together through this. As we slowly come out of the COVID pandemic, we need to stay focused on the future, but not forget what we've learned over the past 2 years. We've learned how to move forward together through the pandemic. We've had to adapt to an ever-changing healthcare landscape to continue to provide our clients with the highest quality of care. The post-COVID world is still ever-changing, and we have to stay up to date on healthcare trends as much as possible and to ensure our patients receive the highest quality of care. This is our third virtual Quality Management Summit. Last year, we had approximately 140 attendees and over 35 agencies represented. So we're super excited to have all of you join us again this year from across the Commonwealth. During the next couple of days, we will be learning more about quality management through our planned activities and special events where you will be able to join in breakout sessions and hopefully network with others throughout the other agencies' websites and discussion groups. We're hoping that this will be our final virtual Quality Management Summit. We're planning to have our next annual Case Management Summit in person next year. So be on the lookout for more details in the coming months. In conclusion, welcome again, and we hope you all enjoy the 2022 Virtual Quality Management Summit. We hope to see you all again in person very soon. Thank you and be well.
Good morning, everyone. My name is Jasmine Christine Ford, and I am the HIV Care Services Clinical Coordinator here at VDH. We will start our summit with presentations on possible future HIV treatments and injectable HIV treatment regimen presented by Dwight Rackley and Dr. Stephen Barnett. Dwight Rackley is the Director of Education for VCU's HIV Education Program. He earned his RN degree from Hennepin University in Philadelphia and holds a master's degree in nursing/nurse practitioner from VCU School of Nursing. He has worked as a nurse practitioner in multiple Ryan White clinics. Dr. Stephen Barnett has over 20 years of experience treating patients in all phases of medical care. He is currently the Director of Medical Education and Physician at CAN Community Health, where he is currently providing care to persons living with HIV. As a credentialed HIV specialist, Dr. Barnett also serves as the Medical Director for Fairfield County Detention Center and Fairfield Behavioral Health Services. Please welcome Dwight Rackley and Dr. Stephen Barnett.
Good morning, everyone. Welcome to the Quality Management Summit. I'm Dwight Rackley. I'm a nurse practitioner. I'm also director of the VCU HIV Education Program in Richmond, Virginia. This morning, I'm going to be talking to you about possible future HIV treatments. So nothing is in stone yet with some of these treatments because they haven't been FDA approved, but these are a few possible treatments that we may see coming down the pike pretty soon. Next slide. For disclosures, I have no disclosures, and some of the slides here I give credit to Clinical Care Options for their graphics. Next slide. Today's objectives are to discuss possible future HIV treatment modalities, and after I finish with my section, Dr. Barnett is going to discuss injectable HIV treatment regimens. Next slide. So what are the most likely to come out of some of these upcoming studies are some of the drugs here. There are many more that are in very early phase development, but these have been in the news, or in the medical news rather, for HIV treatment options that could be in the future. We have islatravir, which is a nucleoside reverse transcriptase translocation inhibitor. It's a fairly new class. Lenacapavir is a capsid inhibitor. A drug that doesn't have a name yet, GSK 3640254, which for future reference down the road, because there's so many numbers, I'm just going to call it GSK 364. There's a Merck drug, MK 8507, and we'll talk briefly about the broadly neutralizing antibodies, or BNABs for short. Next slide. So just to quickly review, because some of these newer drugs that are in development target different different areas rather of HIV replication. So just as a quick review, we know that HIV binds to the CD4 cell. It fuses in to the CD4. It does its thing with integrating its RNA into the host DNA. It replicates, it assembles, and then it comes out and infects new CD4 cells. So we know going back to the 80s and 90s that just targeting one cycle of HIV replication does not work. Two did not work, and so we found out that back in the 90s that drugs working and getting drugs into the system to work on 3 cycles of replication was the main target. And even though we do have treatment options now with 2 drugs, we know that hitting separate sites of HIV replication is the best way to go. Next slide. So here are some of the possible treatment options. Well, one we're already using is, and I wanted to make note of this, which Dr. Barnett will talk about a little bit more, cabotegravir with rilpivirine. That was approved last year. At first, it was given every month, and now it's been approved for every 2 months for patients that are virally suppressed. So cabotegravir, the drug by itself, is also being used for PrEP. So islatravir, which is a drug that's been on the radar for quite a while now, works very similar to how drugs like AZT and lamivudine worked. It's a nucleoside reverse transcriptase translocation inhibitor. It works a little bit differently, but it's in the same kind of field as the other nukes. It's been studied as being given daily, weekly, or monthly. It can be given as an oral medication, or it was also being studied for implants. It's also being studied for PrEP. Had a long half-life, and it had a very high barrier to resistance, and it was quite potent. It was also being looked at as a combination treatment with doravirine, which is a non-nucleoside reverse transcriptase inhibitor. However, not too long ago, the FDA decided to put a stop on the studies because of low white counts and low T cell counts. So that was worrisome, so they put a halt on the studies. However, just last month, they've decided to start studying islatravir again. However, they're going to use lower doses to see if they have the same effect. So keep an eye out on this drug. Islatravir is possibly going to come down the road, but in a much lower dose to prevent drops in white counts. Next slide. Lenacapavir is a newer drug as a capsid inhibitor. So this is a new class of drug. This is a quick little cartoon about where capsid inhibitors work. So capsid inhibitors are working in the very early phase where the virus enters the cell and disassembles its capsid and gets the viral material into the host cell. So this is where GS6207, this is a Gilead drug. It's going to be working in the early phase. Next slide. So lenacapavir is going to be either oral or subcutaneous as an injection. It can be as being looked at as treatment and PrEP. Now, don't forget that this drug will also have to be given not by itself, but it will also need an optimized background. So it'll be other pills or other medications given with lenacapavir. It won't be used by itself unless it's just given with PrEP. The injection has a very long half-life. It can be given as much as only every 6 months. What else do we use with it? We're not really sure, but like I said, you can't use monotherapy with it. You still need an optimized background. It was on hold. Again, this was another drug that was on hold, but it's not on hold anymore. It wasn't due to the medication itself. It wasn't a safety issue. It was an issue with some of the glass vials the medication was stored in. It was some compatibility issues. But as of this summer in July, the company resubmitted for FDA approval, and hopefully we will have approval soon for lenacapavir. So keep this on your radar as well. Next slide. So one of the studies that was looking at lenacapavir was the Capella study. They did see some resistance. However, we still had 3 patients that resuppressed at a later visit. 2 were without, and 1 was out with an optimized background, and 1 had no fully active agent. So they're still looking at this, and as the studies continue to go on and restart, we'll look to see if there's any more emergent resistance. So this is something that we have to keep an eye on. Next slide. So the next class of drugs that we're going to look at over there where the blue arrow is maturation inhibitors. So with lenacapavir, we were looking at early stage. So over on the far left, when the virus is just coming into the cell, that's where lenacapavir worked. Now we're going to go over to the other side in late stage replication and talk about maturation inhibitors. Next slide. So GSK 364, there was a phase 2 study that looked at this new maturation inhibitor. Good news is they saw no grade 3 or 4 adverse effects, and they didn't see any patients having to discontinue the drug, and there were no deaths, fortunately. There were 2 serious adverse. They did have 2 serious adverse reactions, but however, these were not related to the study drug. They had 1 anal abscess and another grade 3 congestive cardiomyopathy. So it looks pretty good so far. Next slide. The next drug, MK-8507, is an investigational non-nucleoside. This is very similar to drugs like rilpivirine and efavirenz. It's being investigated with islatravir, which, like I said, is on hold right now, but being studied in lower doses as combination therapies. We might see this, coming to fruition as a drug by itself. We're not really sure right now, so the future is kind of open for this drug. So we're likely to see more of this in upcoming studies and conferences. Next slide, please. So broadly neutralizing antibodies, or BNAbs for short. Next slide. So BNAbs, or broadly neutralizing antibodies, came to light, and you might have heard about some of these drugs over the past 2 years because they were used quite a bit during the COVID pandemic. So broadly neutralizing antibodies are infusions. So they feature monoclonal antibodies to help neutralize HIV-1 isolates. They target HIV-1 envelope proteins, and they can be genetically engineered to combine multiple specificities to extend the half-life, so they can last for quite a long time. The advantages to this, like I said, it's an infusion and may not be given that frequently. We haven't seen any cross-resistance to other antiretrovirals. There are some paradigms that are very similar, like I stated before, for therapeutic use for other diseases such as COVID, potential for overcoming adherence challenges and less stigma, and the potential to enhance HIV-specific immunity. Potential clinical uses could be HIV treatment intensification by concomitant use of antiretroviral therapy and BNAbs, maintenance therapy in virologically suppressed individuals. A lot of the studies right now are in patients who have already virologically suppressed, and they're being studied with some of these broadly neutralizing antibodies to see if they can maintain viral suppression with just the neutralizing antibodies. So we'll see how that turns out. There's also immunotherapy, so it's a possible treatment alternative for multi-drug resistant patients or patients who are not able to tolerate antiretrovirals for whatever reason. And it can also possibly be used for pre and post-exposure prophylaxis. Next slide, please. So what do we do? What do we need in HIV research? So just to kind of sum up a few main points, there are some progress towards a cure. And as some of you may have noticed, we have had about 4 or 5 patients functionally cured on long-term ART free remission. But we've, over the past 40 years, we've only had 5 patients that were functionally cured out of 38 million cases worldwide. But don't forget, these patients that were cured were also being treated for cancers. So they did have stem cell transplants after they had chemotherapy. So this is not ready for prime time. I remember specifically having patients ask me whether they could get bone marrow transplants or not. But these patients, unfortunately, particularly Tim Brown, who was the first patient cured, he died in 2020 of an occurrence of his acute leukemia. So moving towards combination approaches, we're looking at more and more drug combinations. The HIV guidelines specifically recommend integrase inhibitors currently, but we do have treatment options for virologically suppressed patients like the cabotegravir and the rilpivirine. Two-drug therapy with dolutegravir and rilpivirine has still been is doing quite well. Patients who don't need to be on 3-drug therapy can go to 2-drug therapy if their provider thinks that could be an option and they have no previous drug resistance. Perhaps looking at longer-term injectables, but remember the patients have to continue to be adherent to their doctor's appointments for to get their injectables. Looking at infusion therapy, that could possibly be in the near future. And we also need to do more research into to finding where the HIV hides in the body, or the latent reservoirs in the body. So looking at other cancer immunotherapy agents that might help bring some of the latent HIV out. So that could possibly help as well. And then of course, ongoing vaccine research, which we haven't had a good vaccine come out yet over the past 40 years. So that continues also to be on the research radar. Next slide, please. And to remember to, if you need any assistance with treatment guidelines, check out the DHHS guidelines with hiv.gov, and for more guidance for treating your patients with HIV. Next slide. Okay, thank you very much. We're at the end, and I'd like to turn the presentation over now to Dr. Steve Barnett. Thank you very much.
Good morning, everyone. Thank you for allowing me to come and speak with you briefly. My name is Dr. Barnett. I'm a provider at Can Community Health in Norfolk, Virginia. And what I want to talk to you today about is a new medication that we've had available just recently that is the first injectable HIV treatment regimen. Next slide. The first question we should have is, why injectable? Why do we want to have something we can treat HIV with that's injectable? The number one reason is it's long acting. You only have to have one dose of this medication every 2 months. We do know that this medicine that's been approved is highly effective, and it has very low resistance, meaning you won't have to stop it and switch to other medications. A big component is by having an injection, we get rid of the problems that come with swallowing pills. Some people have difficulty swallowing. And also, if you have significant problems with your gastrointestinal or digestive system, that is, taking pills doesn't always mean that the medication gets properly in your bloodstream. It's not absorbed properly. Big one. If you take this injection, we give it to you in the office, you can't miss a dose. It provides a constant therapeutic, meaning effective, medication level at all times. And then you don't have to remember to take the pill every single day. And therefore, it doesn't interfere with your daily schedule. All of us have busy schedules, things come up. When you're doing this injection, you get the injection, it will stay there at a constant level until the next injection. Next slide. What are disadvantages? The primary is that it requires 2 separate shots in the buttocks. So the medicine can't be combined, therefore it has to be 2 separate shots, 1 in each buttock. You do have to come to the office every 2 months. If you're stable on a daily pill regimen, you essentially get to the point that you only have to come to the office sometimes every 6 months. But if you're doing the injection, it has to be done there. So you have to come to the office every 2 months to get your shot. You can't have pain in the injection site. Luckily, that's rare. And when it happens, it's usually just for the first 2 shots. And then some people just don't like needles. And therefore, if you have significant needle phobia, probably not for you. Next slide. So what do we have? The name of it is Cabenuva. It was approved by the FDA in January of 2021. It took a few months after that to get it available through insurance companies. So we've been using this about a year, although it's been approved almost 2 years. It does provide the complete treatment regimen for HIV. So it just kind of going back there, when we first started treating HIV and got to the point we could effectively treat it, we finally got where you could take a single pill a day, but that pill has multiple medications in it, and so does Cabenuva, and it has everything you need to effectively treat HIV and keep you virologically suppressed. And it's comprised of two components. One is an integrase inhibitor, and that's cabotegravir. It's only found, the only medication that has cabotegravir is Cabenuva. There's no other way to get it. And then rilpivirine, which has been around quite a while, is the other component. That's a reverse transcriptase inhibitor. Next slide. Who can take Cabenuva? Who are the candidates? And the FDA indications list it pretty clearly. You have to be 12 years of age or older. You have to weigh at least 77 pounds. Most importantly, you have to be virologically suppressed to switch to this medication. At this point, and that probably will change with time, if you have treatment failure, if you're taking medication and you're not suppressed, the FDA says that not to use this medicine. If you know that you have resistance to either cabotegravir or rilpivirine, the two medications in this treatment regimen, then you wouldn't be indicated to take this. Next slide. Who can't use Cabenuva? And that is someone that's never been on HIV medication before. So if you just got diagnosed, or you were diagnosed and had never been on medication, we don't use it. Or if you've ever had an allergic reaction to either cabotegravir or rilpivirine. And there are a few medications, if you're taking these, they can interfere. Most of these aren't commonly used, but there are some. So your provider will look at that. And if they see you're on those medicines, they'll either try to get you off that medicine, switch to another one, or we won't be able to use the Cabenuva. Next slide. Cabenuva comes just like this. So when you get prescribed Cabenuva, it either comes to, you pick it up at the pharmacy, or more typically it comes to your provider's office, and it comes with everything you need. The medications in the vials, the syringes, the needles, the instructions for the staff to give it. And Cabenuva can be given monthly or every other month. I will tell you that now that we have a regimen, we can do every other month. That's what everyone chooses. Next slide. They are injections, and the injections are given on the lateral or the outside part of the buttock, just where it shows that muscle there in this diagram. And you get one injection on each side. Next slide. When we start Cabenuva, we have a very detailed way to do it. And first, on initiation, when someone starts Cabenuva, we do have to give an injection at the beginning, a month later, and then we can go to every 2 months. And that's called the loading dose or initiation. Once you get to that point, it's just every 2 months. And there are specific ways, if you miss a dose, how to take care of that so that you don't have to get off Cabenuva. And your provider, the company that developed this drug, has done a wonderful job of educating providers and their teams to know what to do in those situations. And so we do recommend that when you do that, that you stay in close contact with your provider. The main benefit is that when you're getting Cabenuva, you're on that office schedule. So if you don't show up, or if you call and need to reschedule, they can guide you on that. One final thing on initiation. And when this first came out, they recommended that you take the same medicine in pill form for a month just to make sure you tolerated it and you didn't have an allergic reaction. That's no longer required and not even recommended, because they found in the clinical trials, and then once people started using it, there's never been a case of an allergic reaction or any significant issue. It's still available and the company provides it for free, but you and your provider could determine that. Next slide. So the bottom line, Cabenuva, the first injectable HIV treatment regimen, is safe, effective, and well tolerated. 98% of patients that are on Cabenuva achieve viral suppression, and that's as high as it gets with any treatment regimen. Resistance is extremely rare. It's actually less than 1% of patients develop resistance, and there's minimal to no side effects other than that mild injection site pain. That's the most common in about 10%, and it typically only happens at right after the first or second injection. And most importantly, patients liked it. So in the studies, at the end of them, they went to each patient and said, "You've completed the study. Would you prefer to go back to daily pills or stay on Cabenuva?" 9 out of 10 patients said they wanted to stay on the injection. So this is just a brief overview. It's very exciting. We have more and more patients asking for and being put on Cabenuva. I wanted to make you aware, and we will have time for any questions that you have. Thank you for allowing me to present today.
Thank you so much for that wonderful presentation. Now we're open for any questions you may have. You can put your questions in the chat. Okay, we'll give participants a few more moments to type in their questions they may have for Dr. Barnett and for Dwight Rackley. Thank you. Question number 1. And this is for, I believe, Dr. Barnett. Cabenuva pushes doctor visits from twice a year to 6 times a year. Does that create a challenge by increasing visits?
Can you hear me okay?
Yes.
Good. Yes, it does. Theoretically, it certainly does. Like I mentioned in the presentation, one of the benefits to any effective regimen is that eventually you can get out where you're seeing the provider and getting labs every 6 months. So that is, I put that down as a disadvantage. And what we're finding is rarely, and honestly, in our experience, we probably have about 15 or 16 patients so far on Cabenuva. And so far, no one has had an issue with that they've spoken to us about. And we do ask, and we go over it in detail before. By doing Cabenuva, you don't necessarily, and most of us don't, once they're stable. Typically, before we get to the 6-month mark, we're doing about every 3 months, checking the viral load and the CD4 count until stability is demonstrated or durable viral suppression and the CD4 count is normal. What we do then is, in this case, of course, they're coming every month the first time, and then every 2 months. We utilize that, and we don't draw labs every time. So most of the time it's a pretty quick visit, and we have all developed schemes to make that a very in and out process. You don't have to be monitored any longer than any injection you would get in a doctor's office, which is typically a few minutes. So it's typically a nurse visit for about 10 to 15 minutes, but it is more frequent. And we ask patients to really consider that before they make that decision.
Thank you. The next question. Okay. Dr. Barnett, what are some of the challenges in getting Cabenuva?
Good question. Insurance, that's the number one challenge, but we have found that it's gotten much better. And so when I said it's been approved for almost 2 years, but we've been using it for just about a year, the first year, it was on really no formularies. You guys could help me with this because I haven't checked recently. It has not been on the Ryan White formulary. I think there's a movement towards that. So in that case, it's not available. And more insurance will do it. But compared to other regimens, you also often have to do a pre-authorization. Luckily, the company that manufactures this has a program that you can enroll the patient, and they do all that legwork for you and help try to get it pre-approved. I would say right now we're probably in the 60% range for private insurers. What's interesting is, and I love to share this, Humana plan for Medicare is the only one so far, but it has never asked for a pre-auth. If we prescribe it, it's covered. The other challenge is when you go to pre-authorize it, they want to see that the patient is virologically suppressed, which we all know is less than 200. I've had some insurance companies, if a viral load is 50, and they get that confusion of undetectable versus suppression, but it's getting easier. But you do have to tell the patient right up front, we can't guarantee that your insurance will cover it, but, we will do the process, stay on your current regimen. And if it gets approved, we'll contact you and get you in and get you started on this.
Thank you. Question number 3. What happens if someone totally missed the dose of their injection by several days?
Yes. So there's a window, about a 14-day window. So when you get your injection, we schedule you exactly about 4 weeks out for the first injection that's required in 1 month. And then after that, it's every 2 months. We try to put that at the beginning of that 14-day window. And that way, if you miss, we have, depending on when we schedule that, up to 14 days. It's usually about 7 to 10. And that's what I was referring to, as opposed to when you're on a daily regimen. We don't call you every day or every week and say, hey, did you take your medicine? But we have you on our schedule. And if you don't show or something comes up, we have 7 days, at least 7 days, based on the way we schedule. If for some reason none of that works out, we have the option of getting you the pills to take until you can get back in for the regimen. If you do that, it's up to the provider's discretion, but you can go right back to the every 2 month. And I will tell you, that's what I was mentioning. There are protocols, very simple but detailed for each situation. So they have helped us to, make it easy for us. But basically, if you miss, we do have options. If something happens and you just totally miss and you're not on any antiviral after that window closes, then we will treat it as a patient coming back into care that has not been on medication. We can go back to Cabenuva, but we would just get your viral load. If it's already been approved by your insurance and your viral load's not significantly elevated, we'll just go back, but we have to do the initiation dosing over, once a month for 2 doses and then go.
Thank you. The next question has several parts to it. How often does clients need labs after starting Cabenuva? Also, clients need to be suppressed to start Cabenuva. The data says achieve suppression on Cabenuva. Do labs show unsuppressed before settling into suppression over time on Cabenuva?
Basically on the labs, that's up to the provider discretion, but we typically will start the first dose, and then a month later, some of us will go ahead and check a viral load at that visit for the injection, just to make sure that, they came in suppressed before we start the medicine, just to ensure that they're staying suppressed. But you could also do it on the second month. And then once you show they're suppressed, what I typically do is check the viral load every 4 months. So they come in every 2 months, and every other one we do a provider visit and check in with the patient and check the labs. The part about suppression and Cabenuva, the FDA indication is that this is for virally suppressed patients that are on a current regimen. I'm not real clear on that question. Do labs show unsuppressed before settling into suppression over time on Cabenuva? But what I can tell you is, so far, and the data shows this, that if you make a switch and you're suppressed, then you maintain suppression. This is a very effective integrase inhibitor, as well as rilpivirine in addition to that. So we don't see that. And I will say, I actually published a paper on a patient that I got it approved that was not suppressed and had a lot of digestive issues, and had never been suppressed, durable viral suppression for 14 years. She came to our clinic. We tried a few other things. I said, let me see if I can get this approved. And that patient now is 1.5 years out, a little over a year out on Cabenuva, and has maintained undetectable status, which she had never achieved before. So there's other papers out there as well. So the hope is that the FDA will add that indication.
Well, thank you very much. Well, we've run out of time. Thank you for those wonderful questions. Thank you to Dwight Rackley and Dr. Barnett. This concludes our session on what's new in HIV treatment session. And now, consumer reflections and quality improvement projects will start now. To access that session, you will need to click on the link that states join now. Thank you. This is Jasmine Ford. Goodbye.